Hi everyone. Hello. Dr. Amin here. Happy Monday. We have another live today. I will wait for a few minutes. So just people come up here. Hi. Good to see you all. So today we are talking about all about hormone replacement therapy or hormones in general and breast health. And we're talking to lovely Dr. Corinne Menn. She's a board certified OBGYN and menopause specialist, and she's the best person if you have any questions about breast health and you can talk about your concerns. Of course, don't forget this side is just for general evidence-based medicine information, most up to date. So you just update yourself, and we know knowledge is power. So empower yourself with all the evidence base. This is by all means no medical advice. So you can always go back to your doctor with the knowledge about the most up-to-date evidence and talk to your doctor about your health concerns. And feel free, if you have any general question, you can pop it in the comment or in the question bubble. So I give a few more minutes time, and then we're going to invite Dr. Menn for our very hot topic talk. Let me know where you are today and what are you doing now? Hi, Nicole. Hi, Marmar. Good to see you all. So I'm going to find Dr. Menn. There we go. Whilst we're waiting, you can drop your questions, and if you have any concerns, by all means. And if we had a chance to go through all questions, and we can get back to you with some answers and guidance. Hi, Suzanne. So let's see why Dr. Menn is unable to join. I'll try again. It's always like this. Technical issues. I'm not sure why. There is a message here that Dr. Menn is unable to join. Maybe Dr. Menn, you have to invite me or send an invite. So that way sometimes works. Hi.
Hi, how are
Finally.
you?
Good, thanks. How are you? Good to see you and good to have you here today.
Yes, happy to be here to talk about my favorite thing, menopause, breast cancer.
That's great. So before we start, do you mind to introduce yourself to everyone here?
Yes. So my name is Dr. Corinne Menn. I'm a board certified OBGYN and Menopause Society certified menopause practitioner. I'm also a long-term breast cancer survivor, and for many years, my practice has been focused really entirely on perimenopause and menopause for the general woman dealing with it, but with a special emphasis on helping women with premature menopause, surgical menopause, and menopause complicated by breast cancer treatments. Um, so yeah, that's been my passion, and I really feel strongly about, advocating for the women who really have the most to lose when they are going through menopause. And so those are the women with the early, premature, and surgical menopause.
Yes. Great, thank you. So for the sake of the time, I know you're very busy, so I thought maybe we can divide it to three sections and just touch base on these three very important parts of women's life and health. So one, I thought maybe we can touch base on WHI and how just general breast concerns and hormone replacement therapy and how the misinformation created all the hoo-ha and the fear in women or concerns still after many years we see. Number two, I thought maybe we can talk a bit about, again, women at risk with premature menopause due to surgical removal of ovaries and uterus due to different reasons, maybe BRCA positive or endometriosis, ovarian cysts, for any reason, but I think they're pretty at risk. So we have to have somehow help them and guide them to navigate menopause. And the last juicy part is people with breast cancer or breast cancer survivors and their concerns. So much to cover.
Yes. So yes, we'll hit some points, and then I'll kind of like mention some like my favorite resources and stuff, because there's so much to learn here. Each one of these things could be hours long discussions. But the first thing is, it's the elephant in every room. It's the Women's Health Initiative, which is not we learned a lot of very good things from the WHI. We don't want to throw the baby out with the bathwater, but we need to speak about the WHI with nuance and with an understanding of what the study was and what the data actually showed. And, basically the misinformation and the way the media message went out basically caused a legacy, decades long legacy of women and doctors being very fearful of hormone therapy, even that's not what the data said. So we could spend a lot of time talking about this, but I think the most important points are for the listeners to understand that a contemporary view of hormone therapy is what we use now. And we look back at that data and we see that women who took estrogen alone in their hormone therapy, women who didn't have a uterus, and so they were only on estrogen alone, had a lower risk of breast cancer. But it was in the arm of the study that showed a statistically non-significant, actually, if you actually look at how the data should have been calculated. There's been extensive criticism about that arm of the trial. But if we take it for what it's worth, for the way the WHI primary investigators presented, women who used the combination of conjugated equine estrogen, which is an oral estrogen, with a synthetic progesterone, medroxyprogesterone acetate. So those are really not the formulations we use these days, but this is the data that we use to counsel women, right? We say we use the WHI data. So in the arm of that study where they were using the estrogen with the progestin, there was a slight increase in breast cancer diagnosis after 5 years, but not breast cancer deaths. And if you applied the statistical analysis that they said they were going to apply at the heart of the study, or at the start of the study, it would be non-statistically significant. Yet they reported it as it was statistically significant. But it was a very small risk, and that risk is similar to the risk of having family history, being overweight or obese, other lifestyle factors. And so, drinking alcohol. And so basically the risk was very, very small. It was less than, an additional few cases for every 1,000 women taking the hormone therapy. And so it was based on that alone that everybody overnight kind of lost sight of all of the positive benefits that you and I are always talking about in terms of protecting, not only helping with menopausal symptoms, but protecting bone health. We know women who started in the 10-year window have a lower risk of cardiovascular disease, lower risk of sexual, problems, less gender syndrome, menopause. I mean, the list goes on and on because estrogen can positively impact almost every system in your body. So there was a very narrow kind of look that the media ran with and that the primary investigators kind of highlighted at this press conference in 2002, set off all kinds of fear. But as doctors, we know nuances where it's at, right? We need to look deep at the data. And now the Menopause Society guidelines, this is just an easy kind of way to kind of think of it. They've got a very simple statement that says the preponderance of evidence, including the data from the Women's Health Initiative, state that hormone therapy does not further increase your risk of breast cancer, even if you have a family history, even if you have dense breasts, even if you carry a BRCA1 or 2 mutation. So if your risk is elevated, your risk is elevated at baseline. But if we give you hormone therapy, and when I say the words hormone therapy, I'm referring to contemporary hormone therapy that's FDA approved, using, kind of the lower standardized doses, preferably transdermal, but not always. Oral estradiol is great too. And using body identical or bioidentical, so estradiol or progesterone. Not that synthetic versions are bad, they're just not our first line. So when we're using those contemporary options, the benefits for women far outweigh the risks. And so, this fear, it takes a long time to let go of. And a lot of doctors like you and I think we're probably about the same age. We trained in a time where the people who were training us were teaching us, all right, forget it. The WHI came out. We're not going to prescribe HRT anymore. So, a whole generation of doctors grew up not really having much clinical experience. And so that's why your OBGYN may be saying things that are kind of outdated. It's not his or her fault, although at this point in time, I feel like doctors have a responsibility to step up to the plate. Because, and so if anybody wants to see good data on this, read the book Estrogen Matters. They're coming out with a new edition in September and really kind of explains in a really easy to understand way what happened with the Women's Health Initiative, what went wrong with the messaging, and why fear was created. Really helps you sift through the data. And anybody can download the Menopause Society 2022 position statement, which is really, anyone can read it. Hand it to your doctor, and that really sets the record straight, as well. So those are my two go-to sources when we're trying to get rid of some of those myths.
One is asking if there is a replay. Yes, this will be on the Instagram page. You can certainly later watch. And someone, just quickly go through some of the questions. Someone is asking, what if this is not symptom of perimenopause and something else, and I started already on hormones? Am I going to be at risk? So what is your thought on that?
The question's a little bit unclear. So if the symptoms are something else, so say you're in perimenopause and you're having sleep disturbances and night sweats and weight gain and maybe brain fog, I think they're saying, well, wonder if I start hormone therapy, but really something else is going on. Hormone therapy is not going to hurt you. Like I said, the benefits far outweigh the risks. And this is where we talk about having a trial to see if it helps you. When a patient comes in to a doctor, we should always, kind of do a review of systems and just see if there's any red flags for something else that's going on. A thyroid disorder, iron deficiency anemia, some other, chronic inflammatory condition that's going on. But in many cases, perimenopause, it's a clinical diagnosis. So if you have menstrual irregularities and a constellation of classic perimenopausal symptoms, or even if you just have those perimenopausal symptoms and your periods are still fairly regular, but if you're in that kind of average age of perimenopause and you've got like a bunch of these perimenopausal symptoms, it's really reasonable to say like, hey, maybe this could be perimenopause, and it's not going to hurt you to try hormone therapy. It doesn't help you after a few months, well, then, maybe you need to like investigate other things, but it's not going to hurt you.
That's great. Very good answer. Again, someone is asking about worry about the breast cancer. I was watching Women's Health webinar last week, and they are still saying HRT causes cancer. So I'm still.
Yeah, I mean, I just think you have to understand there's a lot of noise out there. There's social media, there's YouTube, there's Facebook, there's people, your family members. It's doctors who are actually not practicing menopause management on a daily basis. That honestly, the doctors are really victims of the medical system too. They were not educated. Less than 7% of OBGYNs and family practice doctors say that they're comfortable providing menopause care. And even in the ones that said they think they're comfortable, less than 30% will actually prescribe hormone therapy. So there's such a huge gap in knowledge. And remember, doctors are in corporate, the corporatization of medicine, doctors are being forced to see patients every 10, 15 minutes. Doesn't allow much time for them to be like, oh, well, let me explain the WHI results to you. It's actually easier for them to say, no, it causes breast cancer. I'm not doing it. Here's some Prozac. And that's what happens.
I know, unfortunately.
That's why I say read the book, Estrogen Matters, and read the Menopause Society guidelines. Yeah. 2 simple, easy things. And Dr. Mary Claire Haver's book, The New Menopause. I think those are like my 3 kind of go-to things where patients can, it doesn't take much time to check out those sources. And I think you need to sometimes have a baseline bit of information even before you go into your doctor so that you're kind of prepared if they kind of push back with misinformation.
And someone is asking about estrogen patch. She started and it worked very well for her, but suddenly symptoms of hot flashes are creeping back. So does she need a higher dose?
Yeah, so I always tell patients, there very often when women have a lot of symptoms and they start on any dose of hormone therapy, any formulation, they're probably going to get some, initial relief of symptoms. It may not happen immediately. I'd say most women feel a bit better within 2 weeks, sometimes even sooner, particularly with sleep and like their hot flashes getting better. And any one dose will probably, you'll know that you're truly kind of getting the full benefit in any one dose by 12 weeks, right? Sometimes sooner, right? And so I often find that sometimes there's an initial, they feel better, but then kind of the receptors, because remember the hormones in your body that are either made by your ovaries or we're giving you, in a patch or a pill, they need receptors to act. And so these receptors in your body, on your tissues, when they haven't seen that hormone for a while, and then all of a sudden you supply that hormone, they may react in one way and, okay, I like this, but then they may need a little bit more over time because there's this very intricate interaction between the hormone and the receptor. So, it's pretty common where we need dose adjustments up and sometimes dose adjustments down. You feel good at first, but then after a few weeks, you feel bloated or too much breast tenderness or you're having spotting and bleeding. And in that case, you got to back down on it, right? That's why you have to, there's a bit of an art to this. And, there's not one algorithm and stepwise way that we must prescribe, right? Because patients always ask me, do we need to start should I start on a higher dose? Do I start on a lower dose? Is the lower dose enough for my bone health? And I tell patients, listen, we've got a full range of standardized FDA approved options, okay? We know they're all safe and actually they're all quite good for bone health. And we don't know which dose is better for cardiac health or maybe brain health because those studies have not been done yet. So we kind of just say, we use the data basically that we have on average doses that say, we know hormone therapy is beneficial for a number of things. We need more studies to look at which doses are better, but we don't have that data yet. So what I tell patients is we pick the dose that meets your symptoms by minimizing your side effects, right? And, and so there is an art to that. And for some women, they need a higher dose for their receptors and other women need a lower dose. But if you're feeling great and someone checks your blood or a saliva test or some other test like that, and you feel really good, your symptoms are all being met, but your serum level is kind of on the low side, people will message me and say, oh, but my dose is low, should I go up? I said, wait, do you feel good? Yeah. Are you having any side effects? No. Why do you want to go up, right? And so you really have to listen to your body. Your body is a living lab. And the only time where this will get to the premature menopause part is that women who truly have premature menopause, that's age 40 or under, and the gray zone between 40 and 45 is considered early, not premature menopause. Women before age 40 need full hormone replacement therapy. We should not be using the absolute lowest levels on those women because the data is extremely clear that their risks of long-term morbidity, cardiac risks, bone health risks, sexual health, brain health, they really need full replacement. But once you're in the natural age of menopause, that's hormone therapy to treat symptoms with some prevention, but it's not full replacement, right? And so that's where I'll lean in on higher doses. And this is where there's a huge gap in knowledge on addressing. So if you think that the regular menopausal woman is kind of suffering out there, the woman who's dealing with premature menopause because of the things that you mentioned, right?
Yes.
Maybe endometriosis, they had to have their uterus and ovaries removed. Or, they had ovarian cyst, or they carry, a BRCA1 or 2 mutation, have not had cancer, so they were having their ovaries removed to lower their risk of ovarian cancer. Those women are going into, menopause surgically in an abrupt manner, so very quick. There's no transition time. And basically overnight, their hormone levels have been dramatically altered. Those women need special attention. And it was a really interesting study that was published, I think it was last year, and it was part of our board certification, one of the suggested articles we read for our required board certification renewal. And it showed that less than 50% of women who had benign premature menopause, so we're not talking about cancer, we'll get there, but had surgical menopause for benign reasons, indicated reasons, but benign reasons, meaning there's no contraindication or controversy about hormone therapy. Less than 50% of them were given hormone therapy. So I tell patients it's like us taking men who are 35 years old, cutting off their testicles, taking their testosterone down to zero, and telling them, I hope you just get on with it. Let me know how it goes. That's what's happening. It's cruel. And it actually goes against, to me, it's medical malpractice because we've got super clear guidelines on how to manage premature menopause, whether it's premature ovarian insufficiency or premature surgical menopause. And the guidelines are clear. You must do full hormone replacement therapy up to at least the age of natural menopause. And people who have endometriosis are not excluded from that. There are ways we can give them back low dose estrogen. Sometimes we give them progesterone as well with endometriosis, even if they don't have a uterus. Because if there's little endometriosis implants out there that might be stimulated by estrogen, we like to give them the progesterone too. And I've had many, many, many endometriosis patients who for a number of years were not treated properly for their premature menopause, and they can very successfully get, have hormone therapy. And there are recommendations on that. But that's a big group of women I see suffer. I don't know about you.
Yeah, yes. And would you offer the birth control pill as a hormone replacement in these people groups?
I don't. If they don't have a uterus, and listen, if they don't have ovaries, birth control pills are not the answer. All right. For younger women who have premature ovarian insufficiency, which is a medical condition that can be caused by many different factors, and they still have ovaries, there's a small risk that they could still spontaneously ovulate. And so in the younger premature ovarian insufficiency patient who's concerned about that, sometimes we will use a birth control pill. And for the much younger woman, they may find it more, kind of socially acceptable. They feel more comfortable taking it as a birth control pill because they're younger and they want to feel like their peers. And so that's not a totally wrong thing to do. But optimally, if we're not concerned about kind of the rare risk of spontaneous ovulation in women who still have their ovaries, using body identical, bioidentical estrogen transdermal with a progesterone. If you have your uterus, you must also have progesterone to balance out the estrogen. If you don't have the uterus, it doesn't mean that you can't use progesterone. It just means that you don't have to use it. And so there's pros and cons to doing that, which, we could get into, but I find that just so many of these women with the premature menopause, for whatever reason, are not being, cared for properly. And it's really, I think it's a real urgent, need. And it shocks me, actually, how many women tell me that their surgeon never talked to them about what was about to happen to them.
Yeah, and I agree. It's malpractice, in my opinion, too. You not give something that your body needs to these people. Someone is asking, I had an emergency hysterectomy a year and a half ago and symptoms come on with vengeance. I'm on Permarine vaginal cream. My estrogen and progesterone are low. Is that enough?
So if she's only on Premarin vaginal cream, then no, it's not enough, unless you have some true contraindication to taking systemic hormone therapy, because of course I don't know, this is not personal medical advice. But if a woman doesn't has lots of menopausal symptoms like hot flashes, night sweats, joint pain, brain fog, vaginal estrogen is not going to help you for those systemic things. Vaginal estrogen is amazing. I love it. All women who, are facing genitourinary syndrome of menopause should be using vaginal estrogen. It's not going to help your other symptoms. And it's interesting, women who are listening who have had a hysterectomy, there's a lot of women out there who get a hysterectomy, say in their late 30s, they're done with having kids and they have heavy bleeding, or, they're perimenopausal in their late 40s and they're really dealing with maybe some fibroids or heavy bleeding. And so they get the uterus removed, but they keep their ovaries. And so they don't have that telltale sign of when they're about to enter menopause because they don't have any more bleeding, right? But what the data tells us is that these women probably go through menopause, meaning their ovaries fail, at least 3 years earlier, which then kind of push ahead. They probably are going through perimenopause even earlier than that, right? So everything's accelerated, but no one tells them that when they take out their uterus. And it's okay. There's a good reasons to take out the uterus sometimes. Many women are much happier, right? They're not having the bleeding. But when you take out a uterus and you keep ovaries, you need to tell women, like, listen, here are the signs of perimenopause. You may suddenly start to have insomnia, feeling more anxious. Maybe you start to have some, vaginal dryness, some joint pain. Just because you don't have hot flashes yet doesn't mean that you're not going through menopause a little earlier. But they're a little confused because they, like I said, they don't have that telltale sign of the bleeding. And many of these women are not counseled that their ovaries might fail earlier. We don't know exactly why. We think maybe it's because of collateral blood vessels that come from the uterus, and when they're severed, when we do a hysterectomy, that maybe the ovaries aren't getting the same amount of blood flow to it, or there may be some other hormonal signaling going on. But for whatever the reason, lose your uterus only, you're still at risk for early ovarian basically failure.
It's interesting that even in one of my, I remember, postmenopause women, she already was in her 60s and she had to go for a hysterectomy due to huge fibroids sitting there. And thereafter, she started severe hot flashes just by hysterectomy.
Well,
So
I think it's interesting because, the ovaries produce estrogen and testosterone. We both know that some women who go through the menopause, they may have their worst hot flashes. The average length of time is 7.5 years. 7 to 10 years is, kind of the typical range that hot flashes will last. But there's a lot of women where it's the worst in the first 2 or 3 years, and their body, their receptors, their brain it settles down. But if you then later on take out their ovaries, now suddenly they're losing testosterone and they're losing some very low levels of estrone that get converted from testosterone to estrone. And so, I think it's like a new insult hormonally to that patient. So I've seen that too, why they're like, oh, I thought I went through this and now all of a sudden it's happening again. And I think it's because there's so little research and the impact of the dramatic loss of testosterone, the specific impact of surgical menopause versus natural menopause. There's just not enough data showing how that's a little bit different. You and I see it in clinical practice, how it's a little bit different. But there was a lot of talk this weekend on social media about testosterone. So you can look back at all the reels. People were enraged because there's some out there saying that women are being, overprescribed, testosterone, where I actually find it's the opposite. I think most women no one's talking about it. They're not being explained it's a female hormone as well as a male hormone. I think the biggest problem with testosterone is that there are some people out there who are prescribing it really inappropriately and are profiting off of like the lack of knowledge from that most OBGYNs have. So they give testosterone pellets that can be very costly and can get very, very high levels of testosterone. But we've got safe guidelines on, how to prescribe it. So go back, you can look some reels I did, and I know you've talked about it too.
So what is the dose you want to start these women that premature menopause surgically removal of?
Yeah. So for premature menopause, ACOG and the Menopause Society both have guidelines on this. And, we're typically looking at like, if you're going to look at an oral, 2 milligrams of an oral estradiol or the equivalent, which is a 0.1 milligram patch. Mm-hmm. If you're going to use the gel, you're going to use one of the higher dose gels, the 1.25 or the Evimis 3 sprays. In my opinion, the gel and the Evimis probably don't get your serum levels quite as high as we can get with the patch and with the oral. So I think the patch or the oral estradiol is my preference for women with premature menopause. So to put it into context, that 2 milligram oral estradiol or the 0.1 milligram patch is a higher dose than the average dose that we're using in a naturally menopausal woman. That would be the average dose would be a 1 milligram estradiol pill or a 0.05 milligram patch. So the average doses kind of raise the serum levels of estradiol to, let's just say, roughly 50 picograms per milliliter. Mm-hmm. The higher doses get it a little bit closer to 100 picograms per ml. And 100 picograms per ml is the average roughly serum estradiol level in pre-menopause, right? Understanding that in pre-menopause it fluctuates up and down, but if you average it over a month, average about 100, right? And so that's why in premature menopause, if we use higher doses, we're trying to kind of get it up to that level. In natural menopause, that's not our goal. Our goal is to meet symptoms, minimize side effects, and those women, there are some who do require the higher levels, others can do great on the lower levels. And so I've got links, I know, in my link tree in my bio to the recommendations because I see a lot of women being undertreated, mm-hmm. In premature menopause. And getting back to the woman who said something about vaginal estrogen, remember, in whether you're premature or regular or old menopause, vaginal estrogen can always be given with systemic estrogen. Because you have to think about it, you'd have to, the estrogen takes, has to travel all throughout your body to get to your skin, right? So putting a topical estrogen on your skin in the vagina, the vulva, the clitoris, and then it gets absorbed into the bladder, that's local targeted treatment. It's not going to replace your systemic hormone therapy, mm-hmm. and your systemic hormone therapy is going to take a lot longer to get, as effective tissue levels of the estrogen. So that's another thing I see is people are not being given both the vaginal estrogen with their systemic therapy.
So, shall we talk a little bit about breast cancer mm-hmm. survivors and if we want to take or how to navigate their menopause to begin with?
So the best thing, first, everyone who is curious in this topic, follow Menopause and Cancer social media Instagram account. It's a nonprofit out of the UK. Danny Beddington started it. The most comprehensive and incredible resources on breast cancer survivors dealing with menopause. What I tell patients is, we have to look at your breast cancer and your menopause holistically. Our first, of course, most important thing is to treat your breast cancer effectively so that you've got the best chance of surviving a long life, right? Once you've completed that breast cancer treatment, then we're going to talk about the rest of your life. So I always like to talk about it in two parts. During treatment, those women need a lot of help too. And very often we're not using hormone therapy then because they're maybe, using, adjuvant endocrine therapy that blocks estrogen receptors or lowers estrogen. They might be on ovarian suppression, maybe taking aromatase inhibitors. So if you're in the middle of treatment and you're dealing with any type of menopause, whether it's early or surgical or treatment induced, the one thing I want you to know is we have a lot of ways to help you. You could work with your oncology team and kind of adjust your treatments to like make your side effects of the hormone side effects not as bad. That's number one. There's lots of ways to optimize it. You can always use vaginal estrogen, and an ounce of prevention is worth a pound of cure, in my opinion. So don't wait for sexual and urinary health to really go downhill. Address it quickly. If your oncologist is being kind of a little cagey about vaginal estrogen, you have to really push. We've got great treatment guidelines. You can have vaginal estrogen. And there are non-hormonal things and lifestyle things that can be incredibly helpful for your hot flashes, night sweats. Once you get through that part and your treatment's complete and you're looking at the rest of your life, that's where we need to have a pragmatic, nuanced approach with shared decision making. Because the reality is we don't have perfect data on hormone therapy after breast cancer, but we do have data summarized really well in a beautiful review article that Dr. Avram Blooming published in the Cancer Journal in 2022. I talk about it very frequently. He also discusses it with his co-author, Carol Tavris, in the book Estrogen Matters. So if you're interested in understanding what does the data say on hormone therapy after breast cancer, those are really good sources. But I always tell patients it's not perfect data. But the majority of the data appears to suggest that giving hormone therapy doesn't appear to increase recurrence. Although there are a few clinical studies that showed it did increase recurrence locally, not distant recurrence or increased mortality. But again, these studies are not perfect. They are limited by size, they're older, treatments have changed, so prognosis is better now, which in my opinion makes it extrapolating this data even more positive, because if it showed not such a bad no negative impacts on patients who were treated 20 years ago, we know women are being treated much better now. But that being said, I always tell patients there are no promises. Breast cancer can recur at 1 year, 5 years, 10 years, 15, and 20 years. Even if you're early stage breast cancer. And so we have to assess what is your baseline risk of recurrence, right? And then we have to balance it. Is like, well, what are you dealing with and what are you suffering with? And what is your risk of the long-term impacts of untreated menopause symptoms and untreated, collateral damages of menopause, whether it's your bone health, joint health, your mental health, right? Sexual health, cardiac health, quality of life. And so, it's something that I think that intelligent people can sit down and with shared decision making, decide, well, okay, for some breast cancer survivors, they make the decision that, yeah, hormone therapy for me personally, the benefits are going to outweigh the risks, but women have to be willing to accept there's an unknown level of risk, that there's a potential that it could cause breast cancer to recur. We've got a lot of data that says it doesn't, but that data is not perfect, all right? We are in urgent need of randomized controlled studies more. We have a few, and if you go to my link in bio, I've done a lot of podcasts where we talk more in depth about all these studies. And I've got a lot of resources there for anybody who wants to dive deeper. But I think out are the days where we just blankly tell women, no, we can't even have this discussion. And the reason why I say that is because we are diagnosing women at a much earlier stage these days. So we've got an army of survivors diagnosed with very early stage disease who've got a long time to live. And they deserve to make choices about their own body, right? And I find that because of lack of education from OBGYNs and oncologists, the medical legal system where doctors are fearful of being sued, let's face it, time constraints, oncologists don't have an hour to talk about this. They are really burdened and really busy seeing so many patients, right? So it's not one person or thing's fault why breast cancer survivors aren't getting access to this conversation. but to me it's unethical because we would not, I always come back to, if we had, you know, millions and millions of male cancer survivors and we just outwardly said, no, you are going to live with zero testosterone for the rest of your lives, I mean, I just don't think that would fly. It doesn't fly. And in fact, in the prostate cancer community, there's been a shift where we, you know, there are more nuance. They can offer these men some testosterone replacement back. There's nuances there. And so I'm hopeful that the tide is turning.
Yeah.
But I'm the first person as a breast cancer survivor to say, I'm very cautious. When I approach this with a patient, but I really truly believe that women, if you give them good information and let them make decisions with you, you know, it's their body, and breast cancer survivors should be able to choose how they live their remaining years, right?
Yeah. So you mentioned about non-hormonal options
Yeah.
for if they decide not to go on hormones, but they want to help themselves. So what are normally, I mean, SSRIs is one of the
Yeah.
that do some cases, especially if they're depressed. So kind of
Yes.
work. What is your recommendation, or what
So,
you
yeah,
normally?
so there's good guidelines on this too. So we have the 2023 Menopause Society non-hormonal position statement is excellent. It's a good resource for patients and prescribers because it has exactly the doses and all the different, you know, medications. So yes, SSRIs or SNRIs. So those are classes of antidepressants. Brand name Effexor is one that's commonly used for breast cancer survivors. Also Lexapro, Celexa. Then you've got you know, gabapentin, brand name is Neurontin. That's particularly helpful for people who have sleep disturbances and nighttime symptoms, night sweats, hot flashes at night. It's a medication, again, these are all off-label use, off-label medication that's often used for chronic pain syndromes, for atypical like migraines. Gabapentin is used for a lot of different things. We don't really know why it works for hot flashes. And remember, all of these things we're talking about are really for hot flashes and night sweats, and then we'll maybe have downstream effects in helping with sleep. But they're not going to help with vaginal dryness, right? They're not going to help with joint pain. And then we have the new medication, fezolinetant, brand name is Veoza. So it is the first, actually, it's the second FDA-approved non-hormonal medication for hot flashes. The first one was paroxetine, one of the SSRIs, got an FDA label for it. And it's a unique medication because it's acting specifically in the thermoregulatory center of the brain. I think it's great. I think it can work really well, very quickly for some women. Little caveat, it was not studied in breast cancer survivors.
Have you seen it in your patients? What's the feedback and
Very
how?
quick. People feel relief very quickly, I find, like within 2 weeks, like, or even sooner. So I think it's a rapid onset of action. I think if it's going to work for you, you know it's going to work for you. Some of the caveats, because there are no perfect medications out there. You know, it's FDA approved. It's said to be safe, but we have zero data in breast cancer survivors. That's number one. It is working on your brain. It's a centrally acting medication, right? We don't have long-term safety data on it. We've got, you know, a few years of data, but we don't know the long-term impacts. Small percentage of women who take fezolinetant, Veoza, the brand name, could have some liver enzyme abnormalities. They tend to go away. They do go away once you stop it, and it's only in a very small minority of patients. So we have to check your liver enzymes, and it could be expensive. You know, it's a brand name only, but it can work really well. And then there is a medication, a bladder medication used off-label called oxybutynin or ditropam that's been found to be pretty effective actually for hot flashes. Side effect is that it's an anticholinergic, which we know long-term use of anticholinergics increase cognitive changes in dementia, also can cause dry mouth, dry eyes. But if you've got hot flashes and night sweats, you've tried the other medications, and you also have an overactive bladder, well, it's going to work on that too. So, you know, I always, when someone wants to talk about hormone therapy after breast cancer, I always make sure we first have a non-hormonal option because I want them to be fully informed. Here are your non-hormonal options. Many of the women have already tried those, and they're like, yeah, been there, done that. Some of them haven't, and so then we'll try to optimize those. And if it's not working for them or they don't want that, then we can, you know, go to the discussions of hormone, you know, replacement therapy. And then within that bucket is a lot of nuances, right? I think, again, we really get into a data-free zone. We don't know what's the best formulation for a breast cancer survivor. I've got some opinions just based on some clinical judgments and kind of understanding the different HRT options. In general, I would start on the lower dose because it just seems like the cautious thing to do. So I start on a lower dose, typically a transdermal estrogen, because many of these women, it's been many years since they've been on hormones. They may be like approaching that 10-year window of optimal time of initiation. So to minimize any clotting risk, starting with a transdermal is great. So we might start with a 0.025 patch or a 0.0375 patch. If they still have their uterus, we're going to use bioidentical progesterone, right? Listeners should know, if you're a breast cancer survivor, particularly if you had ER positive breast cancer or you still have intact breasts, maybe you just had a lumpectomy, there is an FDA approved HRT called Duavie, Duavee. And it's very interesting. It's conjugated equine estrogen combined with bazodoxifene. Bazodoxifene is a cousin of tamoxifen. So in this HRT, you don't take progesterone. It's the estrogen. Because remember, in the Women's Health Initiative study, estrogen alone lowered the risk of breast cancer by up to 30%. And so the drug companies were like, okay, well, we don't want to give the synthetic progestin. Let's pair it with something that will protect the uterine lining. And we know that medications like tamoxifen, they're called SERMs, selective estrogen receptor modulators. So they're like, can we find some other SERM out there that will protect the uterine lining, but also, it's very interesting, it blocks the estrogen receptors in the breast tissue as well as degrades it. So it's blocking and degrading the receptors. Tamoxifen just blocks the receptors. So it's very, very interesting. And so they're like, well, let's pair it with estrogen. So we're going to treat the hot flashes, help with the bone health, other symptoms, but we have to protect that uterine lining. And it's very, very interesting. It seems to be what we know, it powerfully blocks those receptors in the breast. And it is not FDA approved for breast cancer survivors. It's FDA approved for menopause symptoms, right? So general menopause treatment for vasomotor symptoms, hot flashes, and night sweats. But what the data shows is that women have no breast tenderness. They have no bleeding. There's no increased risk, no increased breast density seen on mammogram. There's no proliferation of any of the glandular or ductal tissue in the breast. And there are ongoing preliminary, very early studies looking at using this combo medication called Duavie for women who are diagnosed with DCIS to see if it perhaps helps the DCI regress. Very, very early studies. This is not a standard care of treatment yet. But I think in the oncology and menopause kind of intersection space, for people who are interested in these kind of survivorship issues, this is a very interesting medication. So when I have an ER positive breast cancer patient, I talk to them about either low dose estrogen patch and progesterone if they have a uterus, or consider Duavie. Downside to Duavie, it's expensive. It's a one size fits all. There's no dose choices. It's an oral equine estrogen, conjugated oral equine estrogen, which some people don't want to take for a variety of reasons. But we've got a lot of very good safety data on conjugated equine estrogen. Actually, you really shouldn't be afraid of it. So I think that's a very interesting option. And then
what is the dose of estrogen in that?
The dose is a 0.45. So it's a little bit lower than the dose that was used in the WHI, which is a 0.625. So yes, so I talk to my patients about that. And, we try to make a decision with their healthcare team. We talk to their oncologist, if they're still seeing their breast surgeon, and, they could be tricky conversations. But I find that when everybody just takes a deep breath and we center on the patient, that even a lot of skeptics or people who are uncomfortable with it, if someone else is managing it, they're often be like, okay, if you want to do this, that's okay. They sign an informed consent and we follow them closely. And, I think it's a reasonable, pragmatic way to approach it.
Someone is asking, she's on HRT 15 years, tried to taper, but too many adverse symptoms. Is there an endpoint to HRT, or can it be used indefinitely?
If you're feeling great on it and you have no new contraindications, you could stay on it indefinitely. There was just a big study of 10 million Medicare patients that looked at women who stayed on past the age of 65 versus women who were either not on it or came off at 65. And the women who stayed on it across the board had tremendous benefits, long-term benefits. If you're having side effects, you're not feeling good on it, then you are probably on the wrong dose or on the wrong formulation. And, you can then, try to adjust that or lower your dose. But There is no arbitrary limits on how long you can stay on it.
We're not talking about testosterone, but someone is asking, how do we know if we need testosterone? What test should I ask?
So, yeah, and I saw someone asked about pellets for breast cancer survivors. Listen, a lot of breast cancer survivors get pushed to pellets because their OBGYN, their oncologist won't even discuss with them. So they find these pellet doctors who are like, oh, well, put a testosterone pellet in you. I think that's getting into real data-free zones. First of all, we do not have any good convincing evidence that pellets are better in delivering testosterone therapy than a transdermal testosterone. So I follow the International Society for the Study of Women's Sexual Health. ISHWSH has guidelines on how to prescribe a transdermal testosterone gel, because that's what we prefer, because we can control the dose. It's a daily dose. Versus you put a pellet in, a testosterone pellet in, you can get very, very high levels that can last for weeks to months. And we do not know anything about the safety of getting those super physiologic levels that can happen. And it's just also more expensive. You don't really need that. Do I think breast cancer survivors can talk about testosterone? Yes. It's very, very interesting topic of conversation because we actually know in kind of basic, physiology of how testosterone impacts the breast. Your breast tissue is, kind of living and growing tissue that changes due to hormonal shifts, during your menstrual cycles. And it appears that testosterone's role in a normal, healthy breast is that it basically kind of counterbalances some of the impacts of estrogen on growth of breast tissue. And in general, testosterone appears to be, when properly prescribed, very breast safe, probably very breast neutral, maybe even breast beneficial when it comes to cancer risk. But that's when we're using the physiologic doses that ISHWSH recommends, right? We have no data when we get into these high levels, right? So I think that it's a reasonable thing for a breast cancer survivor to consider. And then most breast cancer survivors, lowering testosterone is not part of their treatment plan, right? So we can check a testosterone level around we can check a testosterone level on any woman, but we know that as we age, our testosterone levels, slowly come down, not abruptly like in menopause with estrogen. And if we remove our ovaries, then, we have, we've lost a major source of our testosterone. So, there are reference values, roughly up to about 45 is the level on a blood test. And so if you get your testosterone levels checked and it's very low and you're having symptoms primarily of low sexual desire, that's what the guidelines say, right? So we kind of talk about it in the idea of, are you having low sexual desire? That being said, we've got a lot of ancillary data, a lot of supporting data that we know lower testosterone levels are associated with insulin resistance, with hot flashes, with sleep disturbances, with mood changes, loss of skeletal muscle, lots of other things, right? I just did a big post on it this weekend, so you can go back and read all of that. It was a review article that I really like about testosterone. And so I think it's reasonable in a breast cancer survivor to say, okay, my testosterone levels are like 3, right? I definitely have a low libido. I've got some of these other things, it's reasonable for them to consider, okay, maybe a low dose of testosterone might be a first step for some of them. Maybe they don't want to even start with estrogen. I think it's reasonable. We need more data on it though. But I think I'm not going to withhold things that I think we've got literature on and that we can have an intelligent conversation with just because we don't have perfect data. Because if you and I are going to wait for perfect data on this, we're all going to be dead. It's not happening. We'll be dead. Yeah. And so, these women have one life to live. And so I can say, okay, here's what we know. Here's what we don't know. Here's a way that we can start, using some guidelines on, a low dose of something, and we can monitor testosterone levels. But this is why we prefer, starting with the transdermal testosterone. So anybody can look them up, ISHWSH testosterone prescribing guidelines. I normally use the 1% testosterone gel that's FDA approved for men, and we just use it in lower doses because I know what I'm getting, but you can also get it compounded from a reputable compounding pharmacist. And that works great too. Sometimes it can be a little bit more expensive. The problem is insurance doesn't cover it, but there's lots of little tricks of the trade on how we can get it to patients affordably. But there's some very interesting data though that testosterone might play actually a beneficial role, particularly in ER positive breast cancer. There is a subset of estrogen receptor negative breast cancer that may overexpress an androgen receptor, and there may be some nuances there. People are going to start hearing about it more. It's called quad instead of triple negative breast cancer. We're going to call it quad negative. So and it has to do with androgen receptors. So I think there's a lot of research and interest in the role of testosterone and androgens on breast cancer risk.
Very interesting. And what's your thoughts on estrogen only and recent news of increased risk of ovarian cancer?
Right. So that was such a poorly written paper and study. It was basically what we call data mining. It's when you look back at old data and try to find associations. And you could find these things when you look for them, but remember the study was not designed to look at ovarian cancer risk. And that paper that came out was widely criticized. If you want to hear, I've got a post on it. So if you want to go back, you can scroll back and you can see what I had to say on that. But the preponderance of evidence tells us that hormone replacement therapy does not cause an increased risk of ovarian cancer. And I think that's a great example of a bad paper, a bad study. It was written by the primary investigators of the WHO. It was a scary headline that created fear, but the devil's in the details. And it really is not really worthy, in my opinion, of a lot of discussion. Not to write off people's concerns, but it was a really poor paper.
I know. And shall we just do another question?
Great.
One last one is IUD and perimenopause, when to do HRT. Symptoms are brain fog, joint pain, bloatedness, and cramps. No periods due to IUD.
Yeah, I think it's so interesting. People who are in perimenopause, when they have a Mirena IUD, which could be great, right? They need birth control. They want help with their bleeding. So if it's working for those things, awesome. But when you don't have the irregular bleeding anymore, say, it's hard to know, when you're getting into the menopause. And so, our kind of knee-jerk recommendation is, well, you only need estrogen alone because you have an IUD. That's your progestin. But the reality is most women in early to the mid kind of years of perimenopause are having a lot of menstrual cycles, whether they bleed or not, because remember, if you're not bleeding if you've got the IUD in. But what's happening naturally in perimenopause is that you have a lot of menstrual cycles where you don't ovulate. And when you don't ovulate, you don't make progesterone. So you've got a lot of cycles where actually you could have some higher levels of estrogen than, some little peaks because your ovaries are trying to pump that estrogen out because they're starting to fail. Or there can be an overall decline in estrogen. But we have to keep in context that is happening in an environment where you're not ovulating anymore. So you don't have progesterone on board. So I see women in perimenopause either with an IUD, either saying, no, you have to wait until you're menopausal to HRT, which is wrong. Or they're told, well, I can give you an estrogen patch, but you don't need progestin or progesterone because you've got an IUD. And I think that's wrong. I think that these women very often, if you just listen to their symptoms, if it's more anxiety, breast tenderness, bloating, maybe some night sweats, progesterone alone can be incredibly helpful in those women. And then I add in much lower doses in the perimenopause because they're still making some estrogen. It's just that the estrogen is either, trending lower or it's having peaks and troughs where there's sometimes when it's kind of high and that's when you feel bloated and breast tenderness, and other times it crashes and it's really low. So if we just give you a low, steady, even dose, it kind of is getting a little buffer zone. But perimenopause is the hardest kind of thing to manage outside of having a breast cancer survivor. Perimenopause is tricky because your ovaries are changing all of the time.
It's very erratic. So you do introduce a small dose of oral progesterone, bioidentical progesterone on top of IUD, so to control PMS symptoms.
Yeah, but if there's a patient who is later in perimenopause and they barely, they haven't had much bleeding, their IUD is keeping their lining really thin, and their main symptom is horrible hot flashes and night sweats. Well, in that case, we may just start with, estrogen. But this is where you have to kind of like look at the woman in context as a whole person. Like, is she earlier in her perimenopause years? Is she later? And ask her more than just hot flashes. Ask about bloating, breast tenderness, her bleeding patterns right before she started her IUD, right? It gives you a lot of clues at guessing, because if we try to measure her blood levels, it's so erratic in perimenopause that we can get, kind of false confidence that we know what's happening just because we've got one or two serum levels showing an FSH just being high or an estrogen low or vice versa, right? So it's not wrong if you want to track levels, go for it, but you're probably better off at just listening to the patient. Once in a while, obviously, some levels can be helpful in a patient where the clinical management is a little unclear. But it really, the discussion always comes down to listen to the patient. She knows her body well.
Exactly. Safest progestin to take in HRT, can tolerate progesterone, and IUD didn't work.
Yeah, I mean, I think that a lot of people who can't tolerate progesterone actually, probably haven't been offered nuances in how they give it. So, if you want to try oral micronized progesterone, a couple tricks that you can use if you're having trouble with it being you're intolerant to it, makes you too sleepy or too drowsy, you can get it compounded as a slow release form. I do this all the time for my patients, and instead of having the oral micronized progesterone that's on the market, it's great. You take it at night and it gives you a pretty quick sedative effect, right? But for some women, that's too much, right? And it's a lot is released at once. So I find, below 100 milligrams sustained release capsule can be game changing.
Very interesting.
Yes, it's really, really can be helpful. It's not expensive. It's an easy and safe thing to do. There's, most women can tolerate the progesterone capsule. It is processed in highly refined peanut oil. Even if you have a peanut allergy, most women can have it because it's such a highly refined version of the oil. But for some women, perhaps that's causing some issues. So you can have it compounded in a different type of oil base. You can also use the progesterone capsule vaginally. So it will protect the uterine lining and it won't give you the GI side effects or the sleepiness, but it will do its job at protecting the uterus. It's an off-label use of it, but it's commonly done. If you've tried all those things and it's still a no-go, it's okay. We have a combined patch. So there's a brand name Combi patch, and that's got norethindrone as the progestin. So I'd say my next go-to from progesterone or the progestin IUD would be a norethindrone acetate, and you can do 2.5 milligrams, at night. And for many women, that will be, it'll protect the uterine lining, and it might be better tolerated than the progesterone. From the data that we have looking at the different types of progestin and progesterone, progesterone appears to be the most breast neutral. The norethindrone acetate seems okay as well. Probably not as good as progesterone, and probably the least breast friendly is medroxyprogesterone acetate. But that being said, it's still incredibly safe. So if you need to use the old school Prempro or to use medroxyprogesterone acetate, it's okay. It's okay. Because remember, the WHI, even in that study, there was very, very low incidence of breast cancer incidence, not death, on people who use medroxyprogesterone acetate. And it really bordered on being statistically non-significant. So if you need to use
Oops, we have some problem here. Oops. Okay, let's see if we can, Dr. Menn. Let's see. We lost Dr. Menn, so I'm trying to invite her back. I know it's well over an hour we're chatting. Let's see if we can find her. Someone is asking, how do I get a doctor to prescribe HRT post breast cancer? If you look in, I will post the video now recording, so you definitely will get the answer. Dr. Menn is unable to join. Let's see. Maybe it's a connection problem because she suddenly went on pause and then disconnected. Let's try one more time. Yeah, it doesn't seem that I can find her. All right, okay. Okay, so I think we should say bye. Do check the video. I'm going to now share it with everyone. It's amazing, so much information, and see you all soon. So drop your any questions you have, and I make sure to get back with some answers for you. Have a lovely Monday. Good to see you all. Great.